chairpersons and my dear friends. My topic today is newer CCBs and ARBs. Is it old wine in new bottle or something new? Well, let us first look at the parameters that should influence you when you decide on a drug, whatever the drug is, whether it is antihypertensive or antiplatelet or anti-diabetic. The parameters will be pharmacodynamic, pharmacokinetic, tolerability, and cost. The pharmacodynamic can be efficacy and potency. And with respect to efficacy, it can be a surrogate marker, like say it reduces blood pressure or it reduces blood sugar. Or it may be with respect to morbidity, it reduces stroke or it reduces heart failure. But probably the most important is that it should reduce mortality. Coming to pharmacokinetic aspects, in a long chronic disease like hypertension, of course, you would like a drug which is orally administered, which is once daily administered, and which has got minimal drug interactions. The drug, if the patient has to take it on a long term, should be safe and should have minimal side effects. And of course, it should suit his pocket. It is not only the cost of the drug, but the cost of the laboratory investigations. Because if you are giving a drug which requires frequent laboratory monitoring, obviously that increases the overall cost. So with respect to hypertension, one should have a drug which has evidence to show that it reduces morbidity and mortality, which, as I said already, should have a once daily oral administration with minimal side effects and reasonably cheap also. So let us come to the hypertensive field now. An ideal antihypertensive should, of course, reduce blood pressure, should be long acting, should be cheap with no minimal side effects. But equally or probably more important is that it should reduce cardiovascular events, preferably death. And if we have data on these things, that it will reduce mortality and morbidity, it will be given in the guidelines, and naturally you will see also in the standard textbooks of medicine or cardiology. So let me start with amlodipine. It was first approved by US FDA in 1987 with an experience of 3 decades with a long duration of action, single daily dose. Even if you skip a dose, nothing happens. The so-called forgiving hypertensives, because it forgives if you miss a dose. Highly effective to reduce BP and cardiovascular events. The most evidence-based CCB for hypertension, and you don't have to check your blood every week or every month because it neither affects metabolic, neither produces metabolic nor produces any electrolyte disturbances. So the major specific advantage of this molecule is its low onset of action, long duration of experience, and the data that it has to its base. Just to show you how much evidence it is, by just 4 trials. There are a lot of trials, but I will only see 4 large trials. The Al-Had, 42,000 patients, 4.9 years. Ascot, 19,000 for 5.5 years. Accomplished 3 years, 11,000. Value, 15,000 and 4.2 years, coming to a total of 88,000 patients for 4.4 years, or 387,235 patient years of experience only based on these 4 trials. Well, in Al-Had, the primary outcome was same. There is no difference. There was a modest increased heart failure, which we know calcium channel blockers do, but significant reduction in stroke and new onset diabetes mellitus also got reduced. The Ascot BPLA, 23% reduction in stroke, 16% reduction in cardiovascular events, 24% reduction in mortality, and even all-cause mortality reduced by 11%. The most important advantage of the new CCBs is said to be reduced proteinuria. But as I said, proteinuria is a soft endpoint. When you look at more harder endpoints, like the renal endpoints, the accomplished, for example, showed that amlodipine reduced it by 52%. And if you look at the progression of CKD, again, there is 48% reduction by amlodipine. And then other lesser aspects of hypertension, like blood pressure variability, which is now coming in a big way. This is the Lancet articles, which showed that visit-to-visit variability is a powerful predictor of stroke and coronary events. And actually, maximum systolic BP is more predictive than mean systolic BP. If you have 5 values, even if the average is low, it is the maximum one that determines the prognosis. Residual variability is an important prognosis, and stable hypertension is any day better than episodic hypertension. So BP variability is important. And we have data, again, sub-study from the Ascot trial, that if you reduce BP variability, it will also prevent stroke And different classes of drugs are superior to others. And the best is calcium channel blockers, of course. Amlodipine is the drug that was tried. And the worst was beta blockers. Atenolol was the drug that was tried. As you can see, when you compare to other classes, CCB comes supreme, best. When you compare to placebo, again, CCB, which is basically amlodipine, comes best. The second other aspect is the central aortic pressure. We know that brachial pressure is not the perfect pressure which the brain, heart, and kidney are subjected to. Brain, heart, and kidney are subjected to a central aortic pressure. And drug treatments differently affect central aortic hemodynamics. Again, we have the sub-study from ASCOT, the CAFE trial. You can see that the peripheral systolic blood pressure is superb. Same, whether you give an atenolol-based regime or an amlodipine-based regime. But the central aortic pressure are totally different. It is much lower with the amlodipine arm compared to the atenolol arm. And lastly, effort angina and coronary artery disease. Well, amlodipine is well tested. And the anti-anginal effect lasts for 24 hours, often better tolerated than beta blockers. And you have one trial also called the Camelot old trial, which showed that amlodipine decreased cardiovascular events 39% versus enalapril despite similar BP reduction. Now, when you come to the newer LN blocking calcium channel blockers, what is missing? Several things are missing. One, the half-life is short. Even though they say you can give it once daily or twice daily, actually the half-life is short. And the evidence are for soft endpoints like pedal edema or proteinuria, and that too are only small open-label studies. No long-term, like amlodipine, there is no long-term outcome studies for cardiovascular event reduction. No long-term studies on EGFR and renal outcomes. It is only in proteinuria, and that is why the approval is still pending in the vast areas of the world. Again, as I said, the most important argument against amlodipine is renal impairments. Actually, reduction in or increase in proteinuria. But there is no evidence that amlodipine causes renal impairment. In all the 4 studies, the indices of renal function were better preserved in the amlodipine group. Maybe you can add an ACE or ARB before adding amlodipine in chronic kidney disease so that you have balanced dilatation of the afferent and efferent arteries. Now, this is a study which we published in the American Journal of Cardiology comparing telmisartan amlodipine versus telmisartan cilnidipine. This is again, we didn't look at the long outcomes like death or myocardial infarction, but the importance is in addition to home blood pressure, we also measured central aortic blood pressure, augmentation pressure, augmentation index, pulse wave velocity, and we also looked at the ambulatory BP also. So we found that as far as blood pressure reduction is concerned, there was no difference between the two. Home blood pressure as well as ambulatory blood pressure were reduced to the same manner by both the drugs. As far as central hemodynamic parameters were concerned, it was inconsistent. While central aortic blood pressure was reduced to a similar extent by both groups, pulse wave velocity was significantly reduced only by the amlodipine, and aortic augmentation pressure and index were reduced only by the cilnidipine group. So it is inconsistent. That trial actually did not tell us where exactly we stand with respect to central aortic blood pressure. So as far as calcium channel blockers are concerned, to my mind, there is no question amlodipine should be the first drug and the rest of the drugs should be alternatives if you cannot give amlodipine. ARBs are more difficult. These are the 8 ARBs that is available because if you go by evidence, if you go by trials, different ARBs have different systems, different situations where different ARBs have been tried. So instead of going into all the trials, maybe I should just tell you the indications because the indications are based on trials. Well, if you look at losartan, there is evidence for hypertension, obviously it is there. There is data on stroke prevention. There is data on reduction of LVH in the LIFE trial. And there is also data on diabetic nephropathy. So these are the situations where you should use losartan. Whereas telmisartan, of course, the largest trial, the on-target trial, showed that it is useful in reducing the cardiovascular risk in people above the age of 55 years and who are intolerant to ACEI. Valsartan has data in hypertension, post-myocardial infarction, and also heart failure with reduced ejection fraction. Whereas candesartan has data in heart failure with reduced ejection fraction and hypertension. Irbesartan has data in diabetic nephropathy also. All the other 3 new drugs have data only in hypertension. So how will you choose a drug when a patient comes to you among all these 8 drugs? Well, if you want to reduce only blood pressure, any ARB, you can close your eyes and give any ARB. But as I said in the introduction, your aim in treating hypertension is not just to reduce blood pressure, it is to reduce events, whether it is kidney, heart, or brain. So I think that is only a very soft criteria. If the patient had a stroke or a patient had significant left ventricular hypertrophy, you should go for losartan because that is where the data is. If the patient has none of these things but is a high risk of developing events, the data is for telmisartan. If there is proteinuria, rising creatinine, the data will be for irbesartan and losartan. Post-myocardial infarction, only ARB that has been tried is valsartan. And heart failure with reduced ejection fraction, the only 2 drugs that has been tried are valsartan and candesartan. So maybe you will have to look at the indication. Unlike calcium channel blockers, which is much more easy, here you have to look at the indication before you decide on the drug. Thus, if a patient per se comes to you with hypertension, nothing else, he has no nephropathy, he had never had a stroke, no LVS, then I think the best drug should be telmisartan, because that is the trial which have shown that it reduces cardiovascular risk. The rest, I think you should look at the surroundings, you look at the associated diseases and decide. Like for example, if the patient has got a reduced ejection fraction, give valsartan, that candesartan being not available here. Don't give telmisartan, but give valsartan. If there is proteinuria, nephropathy, go for either losartan or irbesartan, which is of course not available in India. Maybe the other drugs have same benefit, but as I said, we don't have evidence. So to conclude, let me say, go back to what I said in the original. How do you select an antihypertensive? I think these 4 criteria should be satisfied. Evidence of target organ protection. If there is evidence of reduction in mortality, it will probably be superb. Long half-life, because we now know as I said, a stable hypertension is any day better than an episodic hypertension. Nocturnal BP is very, very important. Early morning surge is very, very important. So you need a drug with long half-life. Cost, very important again, because unless the most important characteristic of any drug is that the patient should take it. And for the patient to take it, it should be fitting to his pockets. And of course, less adverse events to be there. And that is exactly what, this is the latest hypertension guidelines, 2020 International Society of Hypertension Global Practice Guidelines. And that is exactly what they are also saying, what I said. 1, treatment should be evidence-based in relation to morbidity and mortality prevention. Once daily regimen, providing 24-hour control. Affordable, cost-effective relative to other agents. Well tolerated, and evidence of benefits of the use of medication in population to which it is applied. Patient with heart failure, don't give telmisartan, give valsartan or candesartan. So it should apply to the situation, to the disease the patient is having. So I think it all depends on evidence. And if you say telmisartan should not be given in heart failure, it is only because there is no data. If somebody does a trial for telmisartan in hypertension, fine, we can use it. So as things stand today, that is where we are. Thank you very much.
Thank you. Very crisp and clear presentation. But very real practical problem, because our market is now flooded with the Japanese molecules. There is some commerce also behind it. Amlodipine is predominantly an European molecule, backed by large, huge amount of data. And the market is now flooded with acylnidipine, benidipine, and cilnidipine, because cilnidipine, I think it has got a huge market share with a very small data. As sir said, small data. Basically, these molecules are all Japanese molecules, isn't it?
Yeah.
Am I right?
So and they are not cheap also.
They are not cheap. Second, no outcome studies, and no outcome studies are going to come, because to beat amlodipine with these lakhs of population, the number of people needed for the the sample size required will be huge for an outcome trial, which is practically impossible. Then there are two issues. The advantage of the newer molecules, newer calcium channel blocker, is predominantly the claim of reduction in the intraglomerular pressure. Whether that reduction in the intraglomerular pressure versus a better reduction of blood pressure. Amlodipine may have a better reduction of blood pressure without much BP variability. It has to compete with a theoretical possibility of a reduction in the intraglomerular pressure because of the efferent arteriolar dilatation, but no clinical evidence. what should we take it? What should be the take?
I think your first choice should be amlodipine. If there is significant pedal edema, okay, fine. Maybe you can go to other drugs.
And if we can combine the amlodipine with a long-acting sartan, then the edema may come down. Edema
Might come down, but what is your personal experience? In my personal experience, I don't think it really comes down if you add with a sartan.
Yes,
Even
sir.
though theoretically it is there.
Yeah, and it depends upon the dosage also. If there is significant pedal edema with a 10 milligram amlodipine, you reduce it to 5 milligram and add another drug. It may help. And diuretics are of no use in controlling the vascular edema produced by calcium channel blocker.
Correct.
And regarding the sartan, sir has made it very clear about which sartan for which condition. And sartans are now preferred over AC inhibitors because with the Messerly's great paper on
That is
was
another big controversy.
big controversy, but that was the last nail in the coffin of AC inhibitors. And for especially the data in diabetic hypertensive patients with renal dysfunction or a renal impairment, the data with sartans may be better than AC inhibitors. Any comments or questions from the
We
floor?
can actually translate the olmesartan data to amlodipine because in the olmesartan trial, it reduced proteinuria, but the event rate was
Even
higher.
you are mentioning the roadmap.
Yeah. So we can translate it and say reduction in proteinuria probably is not what is important.
The most important thing, I think, you have mentioned everything about the quality of the antihypertensive or on what parameters based on which we will decide on the antihypertensive. One of the most important parameters that is understood, it should be an effective blood pressure controlling drug also. If a drug as a single agent can produce a 2-digit reduction in the blood pressure, that may be a better drug. And if it has the other qualities also, like a long-acting drug, a truly single-day drug, less adverse effect.
Sir, Manjulan sir.
Do we have real evidence that an equipotent dose of the newer calcium channel blocker actually reduce the edema? Do we have evidence? Because the one factor driving all the newer calcium channel blockers is the question of edema. And people are, because the hypertension is a asymptomatic disease and they don't want the patient to come back with a symptom. So that is the main reason why the newer calcium channel blocker.
In the trial which I showed, which we published in the American Journal of Cardiology, 50 patients on cilnidipine and 50 patients on amlodipine. One on either side had pedal edema. And both were minor, in the sense if you tell the patient, okay, fine, patient will accept it.
Yes, sir. It's the vasodilator potency. It shows the vasodilator potency of this drug. Drug is acting. And if you increase the dose of these other drugs, that is benidipine or cilnidipine, it also produces edema. Sir, it's because of its action on the other channels, which produces the efferent arteriolar dilatation. That reduces that is the theory behind it. That is the theory behind it.
Small studies here and there, that is all. No real major trial.
And,
yes, sir.
And this glomerular protection in diabetic patients now, with the advent of SGLT2 inhibitors and widespread use of SGLT2 inhibitors, the small advantage this drug can give on the top of SGLT2 inhibitor with a RAS inhibitor, maybe I think it's negligible.
I think that will be another point worth thinking. Amlodipine plus SGLT2 inhibitor, will it reduce the edema?
Difficult question.
Only losartan. So those patients who have got a higher uric acid level, the choice should be for losartan and not for other ARBs.
Perfect. Yes, Jairaj.
A comment about proteinuria. You mentioned that proteinuria may not be significant, but is a surrogate marker for progression of the renal disease. So obviously we all have significant concern about proteinuria, and definitely amlodipine increases proteinuria. But then if you can combine with ARBs or increase the dosage of ARBs, that can be to a certain extent mitigated. Plus, as you very correctly said, the SGLT2 inhibitors also reduce proteinuria. So now obviously we all give all the combinations, and so that pick and choose whatever drug is effective for the patient. And I fully agree that amlodipine is the best drug to reduce blood pressure.
Anyway, Jairaj sir is there. I also wanted to clarify one point. The amlodipine increase in proteinuria is due to its powerful dilatation of the afferent arteriole, but no efferent arteriolar dilatation.
That's right.
So if some other drug can produce some amount of efferent arteriolar dilatation, the proteinuria may come down.
That is exactly what is happening with the SGLT2
inhibitor.
combinations.
Or sartans.
Yeah.
Yes.
Sajan, last question or last comment from Sajan.
Thank you very much for simplifying it to such a level, because you have clearly mentioned the conditions to be thought of. Excellent. Thank you so much, sir.
Yeah, true.